All right, good. Thanks, guys. All right, so we're going to talk about some crossing techniques. I think what I'm going to stress here is getting good at access is really, really important if you want to get, serious about CLTI. So chronic total occlusions are just really common. Unlike the coronary space where it's more like 15 to 20%, in the peripheral space it's much higher. And so to be a good operator in the space, you have to learn to get across. Access is really, really important. Most of the time in my tibial cases, I'm antegrade in the common femoral, but retrograde can mean all sorts of things nowadays. And getting good at this is really, really important. And then the next step is once you get good at this, sometimes what do you do if the wire doesn't just fly through? So I think really knowing the anatomy and knowing the anomalies and the communications that can be there are really important because a lot of times you're not seeing it on the angiogram, right? The absence of it is what you see, and you have to know sort of what to expect. So taking the right shots. So I see a lot of people who are doing footwork. They're just taking a straight AP shot. But what you really want to do is take these two angles because you can see the plantar arch really looks very, very different. I think Fadi has a good slide where he kind of transitions from the lateral to the sort of cranial shot. But it looks very, very different. So you might be thinking that you're in the right place, but if you flip the camera, you're in the wrong place. Again, anomalies are really common. 10% of patients have tibial anomalies. So here you can see different supply of the foot from dominant perineal arteries. I think in general, we like to, try to true lumen cross, whether it's from above, from below. I think you want to get comfortable with subintimal crossing. It's very helpful in tibial occlusions. And then we'll talk a little bit about reverse cart or double balloon fenestration techniques. Distal access, again, getting comfortable with as distal as you can really helps. External ultrasound, I don't use as much as I did when I was sort of first learning this. I know Fadi probably still does it a lot, but I think they're very helpful to sometimes get you back on track if you're not in the right place. So just reviewing antegrade access. Here's a case. Here's the antegrade access I get with ultrasound. I always want to replace this because I usually like to get a little more proximal, but I just haven't gotten around to it. But put an extra big bend on the micropuncture wire, get access, antegrade. I think it just helps a lot more. I put a 45 centimeter sheath down to the popliteal artery, and that's where I sort of start from an antegrade approach. Here you can see the TPT is diseased and the perineal posterior tibial artery is out, but good reconstitution, so sort of similar in this case. And you can see the wound blush there with the heel wound. So came from antegrade. The reconstitution was a little lower than we like. I think coming retrograde could totally be an option here, but you can see my wires off track. There's sort of an island of reconstitution, but you do see a perineal with the posterior communicating arteries and anterior communicating arteries. And so I agree with Fadi, 15 years ago, we would do these cases trans-collateral, but ultimately, even if you cross, the support is just not there. So retrograde access has really become the go-to, I think, for treating these. Here, I was there. I was like, okay, let's just go perineal to the posterior communicating artery, poke a little bit. Usually, I like to just subintimally dissect above. Here, for whatever reason, didn't really force it too much. And you can see that I did not get back into the artery, so I ballooned it thinking I was doing a reverse cart in the posterior tibial. While that balloon was up, fiddling with the wire, it was like an anchoring balloon. I got through on the right frame, you see, into that sort of second area of reconstitution, first area of reconstitution. And so the reason I show this is, again, I'm sort of off track on the left frame, but if you can take a non-hydrophilic wire, I put a little hook bend at the tip and really direct it. Here we have the calcium as the roadmap. You still can re-enter into the space. So just confirming, did orbital back then and ballooned this. And was able to complete this without needing retrograde access is the bottom line. Again, hockey stick, access, I'm sure there's a talk later on this. We've all had cases where you go retrograde and the wire just flies right through, right? And it's great. But what happens when wires are sort of subintimal in both directions? So here's a woman that came in with these sort of plantar surface ulcerations. She has very, occluded posterior tibial, but you see that she also has an incomplete arch. Her dorsalis pedis is out, and therefore she doesn't have the collateralization, which makes sense. Again, the medial plantar or the plantar artery comes back a little lower than we'd like. We probably could have gotten posterior tibial access here, but she had a really good, well-visualized, digital artery here that we could see on the bottom of the foot. So again, using the micropuncture kit, and I usually like to lead with a V18, we basically got access here. We bring this V18 wire, and you'll see as it passes by my antegrade catheter, you can see that my antegrade catheter is probably off target. When I see that and it feels good from retrograde, I like to bring this base of operations as proximally as I can, because if I dissect proximally, at least I have the ability to sort of bail out with stenting with BVS or DES right now. So we exteriorize the wire, bring everything antegrade, treat it, and you can see here a nice direct flow to the plantar surface. And 3 days later, she already had granulation tissue. Okay, so subintimal crossing. So here's an example. When I get access from retrograde, especially almost all, because there's almost never an easy one, but I like to go with the V18. Part of the reason is hydrophilic, but also because it has a break point very early. And so if I push, I know that it's probably subintimally dissecting and staying within the artery most of the time. So here's an example of I think what you'll say is, very calcified distal posterior tibial artery. You can see the calcium, the cast of calcium on the fluoro. Again, pedal disease. I think there might be an anomaly in the dorsalis pedis. It was a little hard to tell. But we got access in the arch of the foot. And you can see here, this is sort of what I do when I go subintimal. I try not to make the loop very big. I bring a support catheter up closer to the tip. And basically lead with the elbow of the V18 a lot of times to cross. And then once there, again, exteriorizing my wire, I like to bring an 014 hydrophilic wire, usually a fresh wire, not too badly dinged up, to wire into the catheter, whether from above or below. Here, I'm not sure if that's a CSI micro or not, but treated that and got a good result. So double balloon fenestration is, in concept, very similar to cart and reverse cart. Okay, instead of using two balloons, it's one balloon with cart or reverse cart, and I think it works very, very well. When I first started doing this, I always just felt better with two balloons. It just made more sense to me. But since then, most of the time, it's one balloon from one direction. So here's a single vessel perineal runoff with some reconstitution of the dorsalis pedis, as you'll see distally. We came, I didn't like, my wire wasn't progressing from above. I came from below. You can see the wire in the middle frame, though, looks like it takes a little bit of a awkward bend. And so I came back from above and pushed a little harder to the point where the wires were able to overlap. And so when I do double balloon fenestration or single balloon, I always give the advice to right-size the vessel. If you're in a tibial vessel, I like to use 3 millimeter balloons. If you're in a POP, 5, SFA, 5 or 6, okay? I think it works the best. If you take a 3 millimeter balloon and try to do this in an SFA, it doesn't seem to work as well. So I personally line up just the markers. I don't overlap the balloons very much. I know some good operators that overlap a lot more. I'll start this way. If I can't get across, then I get a little more aggressive and I will overlap a little bit more. And even when they're overlapped, I'll take the wire and subintimally try to scrape up the artery to cause a fenestration. So balloons go up, then usually I pull the balloon back a little bit. I make sure my wire is typically a fresh 014 hydrophilic wire. And twirl it, and usually finds a way across. So here we balloon it, and you can get a good result in the AT. Okay, last thing is accessing an occluded tibial artery. So I would say we can do it fairly easy in the SFA, and that's probably where you want to try this or practice this, just because the target is so big. But it can be done in tibial vessels. I think the key is that it cannot be heavily calcified. If you see calcium all through the lumen, this is probably not going to work. You want an artery like this. This is a dorsalis pedis of a patient. You can see some of the calcium flecks, but in general, the lumen, even though it's occluded, is dark. So here's this case. You can see a perineal runoff. Comes back sort of in one of the plantar arteries, but really nothing in the dorsalis pedis. And I didn't put the whole case in here in the interest of time, but for reasons we wanted to open the anterior tibial after the posterior tibial. So ultrasound looked like what I showed you. You stick the needle into the dark center. I use, again, a V18 because it breaks very quickly. And this, once I put it into the artery, I switched to fluoro, and I try to keep the loop very, very small, and then with the 018 kind of catheter right behind it to make a loop similar to what I do in the SFA on a larger scale. So we get up to the point where the artery is open in the proximal tibial vessel, reverse the wire, bring it down, and then continue going forward in the chronic total occlusion in the anterior tibial artery. This one reconstituted in the arcuate, so we got down to the arcuate artery, into the open artery, and then we gave her 3-vessel runoff. All right, that's it. Thank you for your attention.